This is the Doc Nation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of Doc Nation and not necessarily those of our guests or referenced health centers. So, Leah, tell us what you've been up to with your business venture. I know that's been something you've been working on. Not very many doctors that we speak with have this entrepreneurial background and interest of taking the bull by the horns and having an impact in their community. Tell us about what you've been up to lately.
We all talk about the administrative burden in healthcare and, all the extra stuff doctors have to do aside from patient care. And one of those things is credentialing. And so a few years back, I said, I'm going to solve this for us. And that's what I've been working on. So since then, we hired a team, we shipped a mobile app onto the iOS and Google Play stores. We ramped up within the first month to about 700 users. And then, as a first-time founder, non-technical founder, I learned later that we kind of built something too big, too early. Because it started kind of breaking and crashing. So we've been working on fixing those things while also, working on customer and competitive research and things like that. So we're not as far along as I would like, but we're in the growing pain stages that most companies often go through.
Tell us about your journey getting to that stage with your practice. How'd you get into medicine? And what was that kind of turning point where you saw, okay, I need to look outside of the four walls that I'm in, that you were in before?
Well, I actually believe that most physicians do have an entrepreneurial desire. I think most physicians would prefer to have a private practice, but what's happened is the current system has made it so cumbersome and administratively burdensome that they can't. I personally wasn't really one of those doctors originally. I was an emergency doctor practicing, in an emergency department, getting paid either by the hour or via RVUs. And I really, really enjoyed what I was doing and I was happy practicing. I never really, a lot of people are like, you would do so good in private practice. And I'm like, nope, don't want to deal with that. However, something actually happened to me in my practice that led me to want to make a change. So when I was working at a hospital, when you first sign your contracts and your agreements, if you don't read the fine print, you wouldn't know this, but most agreements essentially say, okay, sign here on the dotted lines. We are going to bill under your name. Give us your credentials. Give us the rights to utilize your credentials. Embedded in these contracts also are sometimes non-competes that are now potentially going to be federally illegal, and other things that kind of control how you practice. You're not allowed to refer outside of the health systems. There's little fine print like that a lot of doctors don't notice. Mm-hmm. But because of this fine print, I essentially was giving them a right to bill under my name under any circumstance for any reason. And I also assumed a liability for whatever they were billing for. And so fast forward, I ended up leaving one of these positions, one of the many positions that I signed an agreement like this. And something happened administratively, either purposefully with intent and with malice, or accidentally as an administrative snafu. Either way, the outcome was the same, where they were billing under my name.
What are they billing for? This is really interesting. Yeah. I think doctors, this is that underlining things that go on under the surface that really tell us about what was the billing issue?
I left and they were billing as if I was still there.
Oh my gosh.
There's as an emergency doctor, especially now and increasingly, and most professions in medicine are experiencing this. We have non-physician practitioners such as nurse practitioners, physician's assistants, working in the emergency department, taking care of some of the lower acuity patients. And the way that is supposed to work is they see a lower acuity patient, they come and report to me. I hear the story, I look at the vital signs, and I decide, do I need to see them directly, or can I, give them some advice or allow them to pursue their plan that they were presenting. And then at the end, I sign off on that chart as I supervise that case. I was involved in the decision making.
Yep.
So what they were doing was they were having all these people see patients, and nobody was reporting to me because I was no longer working there. And then they were signing off my name. So that's how that happened.
Wow, how long was this
You're
going,
laughing.
how long was this going on before it was found out that they were using your name like that?
Well over a year. And there were only Medicare, Medicaid claims that they revealed to me, but this was also insured patients and things like that. And there were tens of thousands, close to $100,000 worth of Medicare and Medicaid fraud that was committed this way, and unknown amount in insured patients. So yeah, the health system claimed, oops, whoopsie daisy, I made a mistake, but I personally don't imagine how this could be done on accident.
Yeah.
So yeah.
You said snafu, right?
Yeah.
That's a good word for it.
It's a great word, but I was thinking, I was like, I didn't even imagine this could happen in this type of way, but how prevalent do you think this is?
So this specific type where they're saying that the doctor was there and they weren't, and there was actually a patient being seen, I'm not really sure. I think it's much more common than people realize. And how would we know? How did I find out? How would I even know? The only reason I even found out was because my license lapsed in that state. If I hadn't allowed my license to expire, how long would this have gone on for without me ever knowing?
Would have kept going. They would have continued on.
Right. Until there was potentially a lawsuit or a malpractice claim or something like that. But, even then it's rare enough that it might not have ever been noticed, right? And so how much Medicare, Medicaid fraud is happening, it's hard to say. The False Claims Act, you can kind of look up the cases that they've closed, hundreds of millions of dollars by Sutter Health. There's been a lot of cases. They're cracking down on telemedicine practices, because if the screen says you're seeing a practitioner and you're a telemedicine patient who forgets their name and doesn't even remember, and then your insurance company is billed for a bunch of durable medical equipment that you never receive in the mail, that's a potential kickback Medicare, Medicaid insurance fraud scheme that's becoming more common in telemedicine practices. Saying the patients are having more visits than they are, documenting visits that never happened, things like this. And so that's part of why they're starting to kind of crack down on telemedicine. They gave a lot of, leeway during the pandemic, but they're starting to kind of roll back some of those privileges.
One of the things that you said at a previous episode that we had with one of our guests was how we say the quiet part out loud. And in every single conversation we have, there's always something like that comes up. And this experience that Leah has had, it's like, where is it that these administration teams, they just are so not on the same page with doctors? Because if there's 10 administrators for every one doctor nowadays, which is out of control, and you think about the star player on the team is the physician. They're the one that makes everything possible. They couldn't do anything without the doctor. The doctor is really king and queen here in the midst. There's nobody else that this can flow from. And the disconnect is just so massive.
Well, the problem is they don't view it that way. They don't view us as highly competent, highly skilled workers that are critical for the function of their health systems.
How do they view you?
They view us as replaceable, factory workers who, are not producing enough widgets.
Wow. Hold on. Say that out loud one more time.
I mean,
That's
I mean, this is the quiet part out loud also, right? Like
right.
they are treating us like assembly line workers, pushing out widgets. Those widgets are actually called RVUs, and RVU based incentives.
Yep.
They're how we monetize and qualify, what the value of our work is. And so the doctors that are pushing out more RVUs are going to get the better shifts. They're going to get their weekends off and their holiday requests in, and they're going to get their bonuses. And the doctors that are pushing out less widgets are going to get fired, or get the bad shifts, or not get promoted and not be given a letter of reference if they leave the abusive factory job and try to find another factory to work in.
I have to say, I have to say something here, Justin, because this is my for a second there, I was like kind of out of words hearing what happened to you, your experience there. We've talked to doctors and we're trying to help them find the words or try stand up for yourself, make yourself aware and all these things.
Yeah.
And you are aware of how you are being mistreated, misviewed, and you remove yourself from the game. And those people that are treating you like the assembly workers, they actually behind the scenes, they know that your value is so much because they still have to use your name when you're gone.
Right.
That
Right. There's a
is,
little cognitive dissonance there, yeah.
yeah. Oh,
Yeah.
It's really scary because physicians have been kind of put in a fear-based submission standpoint. And part of why you likely are encountering other practitioners and physicians who aren't comfortable saying the quiet part out loud, or they can't find the words, is because there's this subconscious fear that they're going to be fired and they're going to lose their livelihood. There's something in medicine that very few people really understand or have even heard of called sham peer review. And sham peer review is essentially like let's just talk about it in a way that everybody in your audience can understand. This situation that's happening with the police departments, and there's some cops behaving badly. So, some of these departments have mostly good cops who are doing the right thing and a couple of bad apples, but some departments are really run by crooked cops, And so what happens when there's a good cop, that enters that force? What they might do is create a story about them, over scrutinize things, use little, lines in the bylaws that nobody really even knows or understands or pays attention to point out what they've done wrong, to essentially constructively discharge them or get them fired. And the same thing is happening to good doctors and hospitals all over the US who are speaking up and speaking up for patient safety issues. They'll outwardly say, if you see something, say something. If you see any patient safety concern, please report it to blah, 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 blah. But in reality, they take your name down, they bring you into a quiet room, they ask you your story, and they essentially use Socratic questioning to get you to realize that if you don't shut your mouth, you're going to be fired.
unreal.
So so when I hear you talk about it this way, sham peer review, that sounds like doctors are providing a bogus review of their colleagues. It's a joke, or it's not a non-credible. It's a non-warranted review that's really inaccurate. Is that what you're saying? Is that?
I don't think it's doctors. I think it's the administrators.
Okay.
I know it's the administrators.
So when you say peer review, I'm thinking
Yeah.
doctors reviewing doctors' work or commenting as like expert witness kind of sort of. So this review is.
Let me give you a concrete example. So I was practicing in a very inner city emergency department with extremely high acuity patients, many of whom had severe drug and alcohol addiction, many who were experiencing homelessness, had a lot of psychiatric problems. Look at where I've worked and make inferences on which hospital you think that might be.
Sure.
But in every other hospital that I had worked in with an acuity like this, with this patient demographic. There was always a psychiatrist on call. There were social workers on call. We had security available to do one-to-one sits, or some, medical or somebody to do one-to-one sits with patients who were unsafe.
Okay.
In this particular hospital, they had none of those things.
No.
No psychiatry on call, no security available, no availability for staff to do one-to-one sits for patients who are a danger to themselves or others. And I verbalized this concern within the first few weeks I worked in this hospital. And then I had an incident where a patient attempted to, grab me and push me against the wall, who was actually physically chained to a bed with handcuffs. The police officers brought this person in under arrest and left them with me, and no security, no anything. And this is it's just unheard of in every other emergency department in the country. And I've worked in a lot of places, and I've worked in a lot of high acuity inner city places with this kind of demographic. So that day I wrote an email. Hi, Dr. So-and-so. This is the chairman of the department. I know that I've brought this up before. I just wanted to let you know of an incident that actually was a safety concern. This is part of why I feel it's really critical that we get this kind of staff in place, and blah, 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 blah. 1 week later, I get sign out by another physician on the team. And this person happened to be next in line to become chairman. He was like chairman of that hospital system. So this is a large system with lots of different places. Mm-hmm. And this person left their email open. And I looked at the email. It was like reduced. So like I just opened it up and I saw my name. So of course I read it. And it was basically saying, Dr. Houston is becoming a problem. She's putting in writing these kinds of complaints. This doesn't look good for the department. We're really concerned that this is going to become an issue. And then like a day or two later, I got an email that was basically like, we've received some complaints from the staff that, they feel that you might be unfit to practice. This might be too high of an acuity ER for you, and blah, 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 blah. And so I hadn't known about this phenomenon. So the first thing I did was I immediately called one of my mentors, who is from residency, one of the attendings that trained me, and I told them what was going on. And they told me about this phenomenon of sham peer review, and they told me to leave. And I put in my resignation for that job. But then going back to credentialing in my business, now all of a sudden I have no job. And I have to look for a job, and then it's going to take 4 to 6 months to credential for a new one. So bringing it back full circle, this is a big problem that's affecting doctors who speak up.
Yeah, the last thing that a doctor needs is to have some obstacle to be able to continue their profession, and to work with a system that has a 4 to 6 month wait on even being able to begin to take care of people. If you go back to the conveyor belt, the factory assembly line, doctors have been reduced to factory workers. Where's the patient in the factory? Tell me, because the thing that Neil was underscoring is that we are all about getting the doctor's voice back. If a small amount of doctors said, we're done with the BS, we're done, everything would stop. It would. And doctors need courage. They need boldness. They need the support and the ability. That's why we exist at Doc Nation, to give that support. Anyone who has an employed situation or a business situation, that we all have challenges. And so what are those issues? Bring those to us. We love to eat that stuff up and turn it into a better outcome. So, and this isn't just for doctors. This is for doctors who want to impact their community, which is the patient. Where's the patient in this factory? I'm trying to visualize this, because I think patients need to understand how much, they know that they're getting less and less time with their doctor. And it's obvious. It's not complex to understand that outcomes are getting worse. Proper healthcare is not being given because there is no relationship in 4 to 7 minutes. It's just not enough time. So where's the patient in this factory? Like, where would you put them?
The patients are on the conveyor belt. They're the widgets.
Because you said the widget was the RVU, and I liked how you used the RVU
Well,
as
the
a
widget's
widget
the
because
RVU.
That's
I
the
guess
work.
like the
Patient.
patient is, I guess, I don't know. I mean, I'm just using an analogy.
I know, I don't know where they are, and that's the problem. I'm trying to picture where they are, and it's almost like they don't exist in this picture. It's all about the doctor just producing the RVU widget. It's like, where's the human aspect of what medicine is supposed to be?
Yeah.
It doesn't exist to help people.
Yeah.
And the one thing that it exists to do, it's not doing.
Right. And
So,
and the sad thing is that, and I don't want to sound like a conspiracy theorist, but like the mainstream media has done a really good job of villainizing doctors. Like this, for example, this Doctor Death podcast that's out. It's like, this is like one dude who's totally a sociopath who, unfortunately, we have sociopaths among us. We have narcissistic people among us who are dangerous.
Yeah.
Just like any profession has this, but unfortunately, there's this villainization. Oh, doctors are being bought off by pharma and they're trying to push drugs and, look at this Dr. Death person and let's talk about this weirdo who inseminated all of his patients with his own sperm and like this other guy who carved his name into some woman's uterus. Like, yeah, there's freaking weirdos among us. However, most patients have had really good experiences with their doctors, and most patients genuinely feel like their doctors care. They're just confused because, as you said, we're the main character. We're the ones that are, the value creators in the system.
It's the point of contact.
They think that because we're the boss and we have the MD, that we have control over the system. And that we should be able to, if it was really a problem that we had the ability to fix, we would have fixed it by now, and that we don't care, and we're just trying to also make money and all this crazy stuff. So, and it's a hard narrative to push back on, especially when, they've been really taking advantage of physicians' altruism. Because in order to speak about this stuff, we have to talk about the RVUs, we have to talk about the malaligned incentives, we have to talk about money. And why there's these incentives in place. And as soon as a doctor speaks anything about money, the administrators and the medical industrial complex, the medical machine, will say, oh, don't you care about your patients? Why are you even discussing this?
right.
I'm like, yeah. So it's a bad situation.
Wow. No, but I love what you're doing though, because in Doc Nation, we're trying to help doctors. We want them to stand up. We want to help doctors get control. But you mentioned your business focusing on credentialing and how difficult and arduous that task may be. You said 4 to 6 months credentialing? What
Yeah,
was it?
sometimes longer. I mean, I've had a couple of people tell me that they waited 11 months, 12 months. One person was like, I ended up getting another job, but keeping the thing going. I didn't get credentialed for 17 months. Yeah, it's crazy.
Well, so that Justin, that's what it is. Like if we're saying stand up for yourself, all the way up to the point and beyond of leaving a bad medicine, we got to make it easier. Make it easier to leave. Make it easier to hang a shingle. Make it easier to get credentialed. I love. Thank you for doing
Yeah.
what you're doing.
Yeah, I mean, it's kind of hard for people to understand why credentialing is so critical to solving the physician autonomy and freedom of mobility problem until they really think about it and acknowledge that this lengthy process is what's keeping us essentially tethered to the factory.
That's your access card to get in.
Yeah.
Doctor, patient. There's something in the middle that has broken that relationship, and it's the insurance company. And what does credentialing do? It's the way the doctor gets connected to the insurance company. And I love what you said about patients think that, well, geez, you're an MD, you're a DO. Well, if there was a problem, you probably would have done something about it. You wouldn't just let bad things happen. And so the perception that patients have is understandable. Like if I was not in this industry helping doctors for 15 plus years, I wouldn't have a clue. this would be totally foreign to me. I wouldn't understand. I would think the same thing. And the media, I think, is doing a great job of pitting the bad experience that patients are having as if it's the doctor's fault, when whose fault is it really? It's like the people who are at fault do such a good job of making it look like it's somebody else's fault when they're actually the core reason why the issue exists in the first place. This deception, this misinformation, this deception is the problem.
Well, it's really difficult, it creates a lot of cognitive dissonance when you like have to acknowledge that you are the problem in order to solve the problem, you know?
The
Uh,
humility. You're saying the humility that you have to recognize that. I mean,
yeah, I forget what movie it was. I don't know if it was a Soil and Green movie, but it was like, a woman that was like trying to fight against the machine. And, her day job was like this, working in this factory, and she had like risen to the ranks as manager and blah, 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 blah. And then she finds out that her factory had been funding the very machine that she was spending all of her free time fighting. And if she acknowledged this and spoke about this publicly, her life would fall apart. Her friend group would disappear. Her, family would be impoverished. She'd have no home, blah, blah, blah. And it was like this kind of like crisis of conscience that she had because with this realization. And I think that in most people, the workers in these health systems and insurance companies, they genuinely believe they're doing the right thing. These prior authorizations are preventing doctors from overutilizing and, over-treating, and we're just trying to save our customers money. That's not passed down to the patient, number one. And number two, it's really just refusing to pay for services that have already been rendered oftentimes.
yeah.
But they don't know that, because the rhetoric and the narrative within their system is, we're here to help patients and da, 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 da. And so there's like a lot of confusion in general about what's real and what's not. And so I think that, between this experience of sham peer review that I shared and this experience of identity theft and Medicare, Medicaid fraud that I shared, there's a couple of other stories that I've personally had a lived experience around. After talking to thousands of doctors, most people have one or two actual lived experiences that seem like one-off weird things that only happened in that one place and wouldn't happen. But the collective of all of these little things happening all the time to all of us is the pressure that's being put on the system that's driving doctors out of medicine, driving doctors to die by suicide, driving up the cost of healthcare, worse outcomes. When I started this company, our healthcare system was a $3.9 trillion system. Now it's a $4.9 trillion system. In 4 years, it's gone up by $1 trillion. And, less than 7% of that is actually going towards patient care in the form of actual physician services. And the rest is a bunch of administrative crap, inflated pharmaceutical and device costs, and, nonsense.
Well, we appreciate you sharing your boldness, your courage to really underscore and unpack some things that people don't know about. And we really appreciate you taking the time with us to get the word out and to not just talk it, but to actually do it. You've moved with your feet. You're taking action to make a difference. And well, we look forward to all the people that you're going to be helping get more autonomy, more freedom to be able to do what they're passionate about. Rarely do doctors get into medicine for money. I mean, there's a few, but that's just not. It's too long of a road. There's too many requirements to get there. It's for the passion is the core, and all these obstacles that exist to make that passion. Like you said, why are doctors on day one of their career, they're like, I'm already thinking about my exit. What?
Well, no, there was actually a survey done, I think it was the AMA, and medical students, and 30% of medical students say they don't plan to practice clinical medicine at all. That's outrageous.
Wow.
Yeah.
Dr. Houston, it's more than just appreciation for you today. I'm a fan of yours. I'll be cheering for you. and love what you're doing. Thank you for coming on.
Thank you for giving us a voice and giving us an opportunity to share, and for understanding that most physicians, when they really think about it, they agree with a lot of what I've said. They just can't say it out loud.
That's why we're here.
Yeah.
All right. Thank you.
Thank you.
This has been the Doc Nation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.